concept of what we try to do in medicine and in psychology nowadays is really having a multidisciplinary team. So our team, for example, at Central DuPage Hospital involves a neurologist, it involves a social worker, it involves a neuropsychologist, we've got physical therapy, we've got speech, and so on. So asking for help is something we, in a sense, do when we collaborate together. We're taking our perspectives. And what I'm going to try to present today and give you all the idea of is how can you as a patient, how can you as a caregiver know when is the time to get help and what kind of help is out there. So that's what we're going to talk about today. So here's our learning objectives. We're going to ask, what is the concept of asking for help? What's involved in that idea? Then we're going to learn the issues for the patient and the caregiver. We're going to talk about maximizing independence, because that's related, when to ask for help, and then we're also going to talk about learning how to give and receive help. Before we do that, I'm just going to put this timer so I don't just keep talking and talking for hours. Okay. So Dr. Rizak, who you heard this morning, has said this several times to many patients. He says, don't let the Parkinson's disease control you, control the Parkinson's disease. And that is so true. The goal in asking for help is to achieve the best quality of life for the patient and for the family. So it is in and of itself a collaborative process between the family and between the patient. So what is this concept of asking for help? If you look at the picture on the right top, that's taken in Chicago, a lot of people. So we live in an urban area, most of us, some in a rural area. Those living in urban areas have the opportunity for what we call cooperative interdependence. And that's a study in social psychology. In other words, we can rely on other people, and in fact, by necessity, we have to rely on other people to get things done. So you see all those people there, they might use public transportation, they might live in apartments, and so they're relying on other people. Look at Selfreliance, the picture below that. So if we're from rural areas, where I'm from a rural area, you have to really depend on yourself and to a certain extent some of your neighbors who are close by, but close by might be a half an hour or 45 minutes. And so we have this, in a sense, pull. On the one hand, we've got the idea of we can all work together and work collaboratively, and on the other side, we can look at it as being self-reliant. We often think of them, I think mistakenly, as being opposites. In other words, if I'm depending on someone, then I'm no longer independent. And if we think about it a little bit differently, we can still be self-reliant in an urban area. There we're using maybe more problem solving. And we can also be interdependent in a rural area by depending on our neighbors. You see the gentleman there who built the moat around, or the wall around his farm during the flooding, probably didn't do that all by himself. It was probably a cooperative effort. So I want you to start thinking about when is it appropriate to ask for help. And let's start with just talking about what does Parkinson's disease bring to the table insofar as having a neurodegenerative disease. What does that mean for people, especially when they're first diagnosed? And I have a list of things that happen. People start to question and ask about their physical well-being because they know that's going to change. They start wondering about their independence and their privacy as they go and see more and more doctors and maybe need to get some help in the home. Their self-concept, their perceptions of themselves, the expectations they have if they're in their late 60s and 70s, those are supposed to be the golden years, they're retiring and so on. Those start to be questioned. How about roles? Am I a spouse or am I a caregiver? Or am I both? And can I be both at the same time? Relationships with family and friends. Maybe I don't want to go out and eat as often, or if I go out and eat, I'm only going to get a sandwich because I can really hold on to that. Economic well-being. Not all my medications are covered by Medicare or the other insurance that I have, and so that starts to become an issue. I've put away so much money for retirement, and now I'm not sure if it's going to be enough. And then life goals and future plans. So I had some plans to retire one place, and now maybe I need to be near a major medical center. So it changes our whole perspective. In an immediate sense, we can also go through a grief process, and this affects not only the patient, but also the family. And one of the models for that is from Kubler-Ross, where we might have denial at the beginning. We just can't believe that's happening to me. Why me? We might get angry. There might be some bargaining. Please, God, don't let this happen to me. There can be some depression. The goal is to ultimately get to some accommodation, and that's what we're really moving towards today, that help can get us to accommodate that disease. And as Dr. Rizek said, not let the disease control us, but let us control the disease. The thing that makes this complicated between the patient and between the caregiver is that people can be going through different stages of grief at different times, and sometimes you can get some conflict. So one person might be angry, the other person might be depressed, both might be angry, and so on. So this is kind of the background that's going on when we start talking about this relationship of caregiver and patient. And here's some of the moderating factors as well. So on top of that, what about our culture? So cultural background, our spiritual perspectives, do we believe in God or not? A person's capacity to cope. Maybe the person used to decompensate with a hangnail. Now they've got something major going on. And also people's experience genealogically with disease. So some people have grown up with grandparents living in their homes, and they've seen diabetes, they've seen seizures. Other people never been around older people, and all of a sudden you've got one spouse who has the experience of maybe being a caregiver to grandma, and you have another spouse who's never been around an illness, and all of a sudden they're throwing in this together, and how do they react to it? And it depends who has the illness and who doesn't. And then let's look at what's the perspective that we clinicians, we doctors bring to the table as well. I mean, the first thing we try to do is identify what is it. Is it Parkinson's disease? Is it Parkinsonism? Is it essential tremor? What is this? We want to understand it as best as we can, and then we want to manage it. And how are we going to manage it? Well, first question we ask is it something reversible? Is there something we can do that will reverse this disease this person is presenting with? If not, is it restorable? And we heard an excellent presentation on the LSVT big, and yeah, some parts can be restored. Voice, for example. We saw beautiful examples of movement. But if we can't really go back to baseline, then what can we do? And that's the last point here. We delegate, we ask for help. So we say, let's get a caregiver involved, let's get technology involved, and in some cases, maybe we need to have a facility involved. So those are the decisions we come with as doctors. Now, what's the patient's perspective? The patient's perspective with this, again, put in the background cultural, put in the background how am I reacting to this, my loss reaction to this, but how does the patient react? Question and a fear of loss of independence. Possible loss of privacy if I have someone coming into the home to help me, or if I need help in the bathroom, even if it's my spouse. Adjusting to new routines. And the other thing is there are some brain changes that go on with Parkinson's disease that can make a challenge. And one of them is executive dysfunction. That's the front part of the brain. And there's really three areas that we see changes in. One is apathy. And a lot of people will come to us and say that, gee, we can't get our spouse motivated to do things. If you put that again in the context of someone who might need a caregiver, and they're pretty independent, and you say, you know, you need to identify some help and get some help here, and you tell them that on Tuesday, and nothing's happened on Saturday, and nothing's happened a month from now, and nothing's happened 2 months from now, that can get very frustrating to the relationship, plus the patient's not getting the help they need. Inhibition is something else that can change, and that can also complicate one's ability to accept help and to ask for help. So I might say, sure, bring someone to help, and you hire a caregiver, and they come in, and I say, why don't you come sit on my lap? Very inappropriate. So sometimes we see those impulse control disorders where somebody wants to go gambling, they have trouble controlling those impulses. And then we've got problems with flexibility sometimes, where people have a hard time really looking at two aspects of a problem, and that goes into really making a decision, an informed decision. So we've got to keep that in mind as well, that executive function can complicate this whole decision-making matter. So I might sit down and try to say, gee, you need to have a caregiver for these reasons, and the person might have some trouble understanding that. And that can be very frustrating to me as a caregiver. And then finally, there's the limited resources. Maybe I don't have a big social network. I've always been kind of an independent guy, and I don't have a lot of friends, and I don't go to a house of worship, and maybe my finances are limited. So that's the patient perspective. Now let's look at who are the caregivers. So I always say the Y chromosome, not so helpful, because as you can see here, 65% of the caregivers are women. And what we find, 66%. And what we find is that that older adults almost exclusively rely on their family and their friends for assistance. So there's a great burden on women in our society. And in fact, women are nearly half of all workers. And mothers are the primary breadwinners or co-breadwinners in 2/3 of American families. And yet we have a lot of women dropping out of the workforce or having to go from full-time to part-time in order to become a caregiver for their spouse or for a loved one. And so that's a burden on them. That can be a burden on the family too, especially if they're of the sandwich generation. 4 out of 10 caregivers say they had no choice in becoming caregivers. Women caregivers are almost 6 times as likely to suffer from depression or anxiety. And their physical health can suffer as well because they might not go to get help. 2/3 don't take advantage of preventative health services such as mammograms. Okay, so I don't mean to depress everybody. Those are the challenges we've got. Now, what are we going to do about it? Because we can do something about it. We can be proactive. We don't have to be victims of this. First of all is preparation. So whether you're going to be a caregiver or whether you are the patient, in fact, both need to be looking at a couple things. How do we prepare? First thing is, it's really good for the caregiver, the loved one, to go to the doctor's appointment. Studies show when you go to see your doctor, all of us tend to remember about 2 things that he or she told you and the emotion with which they told you. And yet what do we do when we're in the office with somebody? We're telling you this and we're giving you this, and yet with an electronic medical record you get an after visit summary and you read it and you go, what does this mean? Over information. It's good to have 2 people listening. Power of attorney for healthcare. How many people in here have filled out a power of attorney for healthcare? Raise your hand if you filled out a power of attorney for healthcare. Next week, go fill out a power of attorney for healthcare. That preserves your ability to control who makes decisions for you if you are unconscious or if you are so ill that you're not able to make your own decisions. So important. We're going to talk in the next slide about taking stock of what are the issues if I'm going to become a caregiver or if I'm going to have a caregiver. What are the issues we have to look at? And then, of course, looking at finances. Then there's the self-care aspect of it. Got to make sure as a caregiver that you keep your own medical and dental appointments. You want the caregiver to stay healthy because an unhealthy caregiver is not going to be able to take care of their loved one. So we got to make time for that. And we might say, well, we don't have time for it. But if someone has a heart attack, all of a sudden we've got a patient who does not have a caregiver. So we want to do those preventative things, keep people healthy. And then we want to look at what are our resources for getting help and how do we foster a good relationship between the patient and the caregiver? If you go on the internet, there are some wonderful resources if you look up for getting help. And this is one of them called Net of Care, Information and Resources for Caregivers. And one of the things it talks about is how do you take stock of what are the issues if you are going to be a caregiver? Or as a patient, what are some of the issues that your caregiver has to address? So one is determining the daily needs of the patient. Does the patient need help in the shower? Are they unsteady? Or maybe they're completely independent in that. Are they able to cut their own meat or do they need help with the meat? So taking stock of what are some of the things, literally making a list so you know. Deciding what needs you as the caregiver can do on your own and what needs you would really want to delegate out. Or as the patient, what things can you do on your own and what needs do you need help with? Identifying family or friends who you can turn to ask for help, or maybe from your house of worship. And establishing the need, if necessary, for outside professionals. Do you need to go to one of the home care agencies? Do you need to go to one of the caregiving agencies and ask for some help maybe once a week? Now, help for the caregiver. So we know there is a risk, a 60% risk of clinical depression in caregivers. So how can they get help? They can get help by coming to informational meetings like this. Information is power. They can get help by going to a support group. Support groups are amazing, and that's actually how we get our best information, and we get ideas as to what are the needs that our patients have. Going to a psychologist or a social worker or counselor with experience in Parkinson's disease. And sometimes I'll hear, I saw a patient yesterday and I said, you know, it would be really good, because he's not that active. I said, why don't you speak with our social worker and let's see what's available, some resources. And first reaction was, I'm not going to a social worker. And I explained, but this is a social worker who knows Parkinson's disease, who's specialized in Parkinson's disease. And that was enough for him to decide to go. And our social worker, Debbie Crystal, is subspecialized in Parkinson's disease and has very good resources that she can give to people. So you want someone who knows Parkinson's disease. Internet chat rooms are now available. So if someone is good on the computer, they can actually put out a problem they're having, get some resources. As I mentioned, the national caregiver organizations and regional caregiver organizations. I often tell people, go onto the APDA website, and if you have a problem, look and see if anyone else has addressed it. Do a search. Very handy. I've used that in order to make recommendations for some of my patients. The other thing is we can have apps. So I mean, we almost all have our smartphones, and if you have a smartphone, you can get apps, and there's different apps out there. One's called Lots of Helping Hands, one's called Care Zone, Making Care Easier. A lot of these are free, and you can have like a shared calendar. You can put different events. How is the caregiver doing today? How is the patient doing today? And the people that are supporting you can actually go on there and find out what's going on, look at the calendar. Maybe I can help on Sunday if you can help on Tuesday, and that sort of thing. So we have technology now that makes this easier as well. So how do you encourage caregivers that they might need help? How do you encourage patients that they might need help? The one thing you want to avoid is the straw that breaks the camel's back. In other words, I told you, and now this proves that you need help. Not really a good idea to bring it up at that time, is it? You want to really find a time where you're both kind of calm and just, you know, talking about things, and just say, you know, we need to kind of talk about if this and this happens, how would we manage that? I don't think we can do that on ourselves. I don't think I can do that by myself. Do you have some ideas? It's going to be a cooperative thing, because if the patient doesn't buy into it, it's not going to work out, and if the caregiver doesn't buy into it, it's not going to work out. And maybe you can't talk about it now, but I brought it up, and maybe I'll bring it up next week to you, and I'll bring it up again next week, and one of these times you'll be ready to talk about it. So it's got to be done as calmly as possible, and some people aren't quite ready to hear it, or maybe they need to bring it up as their idea, and that's okay. We want to foster a good relationship, and communication is very important. One of the things with communication is understanding what Parkinson's, again, does with the brain, and one of the things we hear is slowed processing of information. So not only slow movement, but slowed processing of information. So you want to make sure you don't give too much information if you're giving your reasons why you think you need some help. You want to use shorter sentences, get the point across. Give the person time to respond. I had a patient last week I was testing, and I asked them to remember 3 words. I think a lot of us have had that test asked for us. And I said, can you tell me the 3 words I just said? And I had to wait about 20 seconds, which I'm not going to do because I don't have that much time, but that's a long time. If someone doesn't talk for 20 seconds, that's a really long time. He got all 3 words. But if I had given him 5-10 seconds and then gone on to something else, we would have said he did not recall the words. So he knows the words, but the slow processing was there. So give people time to respond. If you can't hear them, encourage them to speak loudly, because we know that's one of the things we see with Parkinson's disease. Please speak a little bit louder. I'm having some trouble hearing you. Use active listening. Say, so in other words, what you're worried about is if we get somebody once a week, given how much you're getting from Medicare, that's going to deplete all your funds. Is that right? Is that what you mean? And they might say, no, that's not what I mean. I just want to make sure I can go on that vacation I've been looking for, and I'm not going to be able to go on the vacation. So clarify the meaning. That tells them that you're listening, but it also figures out where is the problem. You might assume the problem is in one area where it's really in something else. And there can be some trouble, like I said earlier, with that multitasking. So write down the pros, write down the cons, and let them look at that so that they can really digest that and make a decision as to, okay, maybe it is time to get some help. This person, Wendy Lusbader, is a social worker specializing in, among other things, caregiver-patient relationships. And this is a quote I'm going to read that she had said. Giving help eventually embitters us unless we are compensated by at least appreciation. Accepting help degrades us unless we are convinced that our helpers are getting something in return. So she's talking about that stress that we can see in a relationship of patient and caregiver. And the next few slides I'm going to tell you some of the points she's made of how can we improve that relationship so that it can be a positive relationship rather than being a source of stress. So one is moderation. I said you want to look at the tasks that you need to do or the tasks that the patient needs done. You don't want to come in like gangbusters and take over and say, this is how we're doing this and we're going to do it this way, even if that's the more efficient way of doing it. If someone's used to doing it a certain way, you want to honor that. You want to honor their preferences. So you don't want to threaten their independence. Maybe that's not the most efficient way to look at finances, but if it still works and that's the way they've always done it, so be it. Identify giving opportunities. I like that picture there. So that gentleman there is folding some towels while his daughter is working in the kitchen. Now she could probably fold those towels a lot faster, but what does that do? They're both in the same room, so there's, the togetherness, and also he is helping, because it still would take her time to fold those towels. So you want to identify things that the patient can do, and that's good for our self-esteem. You want to also take care of identified needs, and here I'm thinking the caregiver-patient relationship is a little bit different than what we think about. So there we've got Jim Baker, who was chief of staff to President Reagan. He wasn't a caregiver, actually. What was he? Chief of staff. So he would anticipate Reagan's needs, give him the papers. In the morning, Reagan would come into the office and he would have all the newspaper clippings of that day that he was supposed to read and review and so on. So again, the caregiver can be somebody who is facilitating for the patient so that they can actually be successful in what they want to do. So you can kind of think of it a little bit different. It's not a dependence, it's an efficiency type of relationship. And finally, dignity and routine is really important. Look at the lady on the left there. She's looking out the window, waiting for her daughter to come and to help her with those daily activities. And daughter called and said, I'm just swamped. And look at the gentleman, in this case we have a son here, with all those post-it notes. So he's swamped at work and he said, I'll get there sometime, Mom. I'm just really busy. And she's waiting there. And how does that make her feel? So they call it the tedium of anticipation. And then you've got the caregiver thinking, after all that she or he has done, and he's done so much for her and she doesn't really appreciate it. Because when he gets there, she's been waiting there for over an hour at the window looking out, and he finally gets there and she goes, well, where were you? I've been waiting. And so it causes all sorts of problems that don't need to be. If you can establish a routine, just like you would an office meeting, and say, this is when I'm realistically able to come. I can come on Tuesdays at 6:30, and I can come on Thursdays. That way the person is not just left in limbo. So a predictable, realistic schedule is really more respectful. Patients often have a fear of abandonment also. They're worried that because the person looks stressed out, that maybe one more thing and they're not going to help them anymore. So they're always kind of trying to be careful. They might not ask them for the help they need. Maybe they're not eating any lunch because they're having trouble getting into those frozen foods that have been left for them to put in the microwave. But they don't want to mention it anymore because the last time they mentioned something, she yelled at them. So you need to have a candid dialogue and just kind of say, okay, what's working, what's not working. And then finally, you've got to take time to enjoy things. So you're busy, you're the caregiver, you came over here, you've got an hour and a half, your kids have to go to soccer, and mom wants to look at some pictures in the scrapbook. And that's Joan London on the bottom picture there. Take the time and do that, because in the big picture of things, emotional memory is so strong that mom's going to remember those few minutes, and that's probably going to make her feel a lot better than getting the laundry done. The laundry can wait. So it's important to keep those special moments there. So here's what we tried to really present to you today. What is the concept of asking for help? It doesn't have to be independence or self-reliance, and they're mutually exclusive. Those can actually be more an idea of being cooperative and also being a problem solver. What are the issues for the patient and the caregiver? So think in terms of not only what are your physical needs, okay, you need help, I need to be able to cut up your meat, you need help in the shower. We don't need to just think of those, but where am I psychologically right now? I just got this diagnosis and I'm not ready to accept it. And you're coming in like gangbusters telling me what to do. And maybe you're upset because you were expecting mom or dad were going to take care of the kids because you've got this career. So look at where people are coming from. Maximize independence. So important to make sure that we're doing everything we can medically. Keep the person healthy. Are they seeing their doctor once a year in addition to seeing the neurologist? Is that vitamin B12 where it ought to be? Is that TSH okay? Getting all those medical tests. Are they kind of hard of hearing? That's going to cause a problem. That's going to make them more independent. Do they need hearing aids or do they just need the wax cleaned out? And so on. So we want to keep the person as independent as possible. That's going to help them to feel better physically and psychologically and emotionally. And the caregiver can really focus on what needs to be done. And that can help avoid the caregiver stress. When do you ask for help? At what point? At what point as a caregiver should you ask for help? At what point as a patient should you ask for help? Lustbader says that a line that you don't want to cross as a caregiver is when you start to resent the care that you're giving for your loved one. When you start to feel angry inside. Then you've kind of crossed that line, and that's when you want to ask for help for sure. And it's not an all or none. You might just need a little bit of help. For the patient, when you realize that you're not doing well physically or emotionally, or you notice that the caregiver is becoming very stressed out and you're worried that they're getting depressed, that's when you want to encourage them to get some help. That's when you want to accept some help for yourself. And that whole giving and receiving relationship, we need to be sensitive to each other. Establishing good routines and expectations can be very helpful. So this whole thing is a process. It's different for everybody, but think of the different factors as you go through this journey of, do I need a little bit more help? Am I doing okay right now? Might I need some help in 6 months, in 2 years? And remember, this is how really life works. If I get a flat tire, I'm calling AAA. I'm getting their help. There's nothing wrong with doing that. We've got the resources. Use the resources. Stay healthy. So thank you very much for your time, and thank you for being here.